Good evening, everyone, and welcome to our webinar tonight, Improving Healthcare for People with Intellectual Disability, the Role of Primary Practice. I'd like to start tonight's meeting by acknowledging the people of the Wiradjuri Nation and the different nations on which each of our participants meet tonight. I warmly welcome Aboriginal and Torres Strait Islander Australians who are present here tonight. A little bit of housekeeping before we start. If you can't see your control panel, just click the small orange arrow at the top right of your screen. Everyone's automatically on mute. So if you have questions, just pop them into the questions box. If you're phoning in tonight, if you can please email your name so we can capture your attendance to cpd@wnswphn.org.au. We're recording the webinar tonight. Tonight's presenters are Dr. Yong-Hee Kim, who's a rehabilitation specialist from the Specialist Intellectual Disability Health team. And we also have with us Kelsey Davis, who's a senior speech pathologist from the Specialist Intellectual Disability Health team as well. We might hand over tonight to Kelsey to start.
Hello, and I'm just going to double check that you can see my screen now. I think so. So welcome and thank you everyone. Oh, sorry.
Sorry, Kelsey, if you just hit display settings and change it to just up the top there, that's it. That's it. We'll have
Very
full
good,
screen.
thank you. Thank you, and welcome to our presentation tonight from the Specialist Intellectual Disability Health team. I appreciate you all taking the time out this evening to listen to what we have to say about intellectual disability. So I am Kelsey Davis, the Senior Speech Pathologist for the team, and we also have Dr. Yong Kim as well, who is our Rehabilitation Specialist. I would also like to acknowledge the traditional custodians of the land we are meeting on and remind people that we live and work on Aboriginal land. I also acknowledge the Aboriginal elders of this community, those who have passed, and all Aboriginal people attending this meeting today. So our learning outcomes, we're going to discuss medical disorders associated with intellectual disability and some screening tools, some assessments and screening tools that can be used with this population as well. We will then talk about some health literacy techniques to support people with intellectual disability to understand health information. And then lastly, we will talk about the Specialist Intellectual Disability Health team and describe the criteria needed for referral into our team and a little bit about what we do as well. So I've just included the contents here. So for anyone wanting to look over the slides later, it's an easy navigate. So I wanted to outline that there are, in 2015, there was 500,000 people in Australia with intellectual disability. And at the same time, almost 2% of the entire population living in Western New South Wales Health has an intellectual disability. I'm going to hand over to Yong now to talk a little bit more about intellectual disability, and I'll be back on a bit later to talk about some other things.
Thanks, Kelsey. Give me 1 second. Can everyone see my screen okay?
Yeah.
Okay, intellectual disability historically was defined based on IQ scores. So the Stanford Binet was one measure, one way of measuring it, and Wechsler is another common measurement method. But nowadays we are heading more towards, I think we are considering more on adaptive functioning. So Vineland adaptive behavior scale or adaptive behavior assessment system, those are commonly used measurement for adaptive function. So adaptive function is basically what people can or cannot do in real life situation. On the other hand, IQ score, they are still sort of measuring general intellectual and mental abilities. They are pen and paper based tests and heavily focusing on language and symbols and numbers. So nowadays we use DSM-5 to diagnose intellectual disability, and we already touched upon criteria A and criteria B, which are general mental function and adaptive function. The criteria C is the onset, so onset during developmental period or before age of 18. And DSM-5 also provide quite detailed specifiers according to severity. So DSM-5 classify ID into mild, moderate, severe, and profound. And those functional deficits can be categorized in three domains: conceptual, social, and practical. And we met patient KY a few months ago at our clinic, and she might be a good sort of example just to go through this specifier. So she was in her late 50s and referred to us because she had this 18 months of gradual functional decline. Her pre-existing diagnoses were intellectual disability, but no severity specified, and cerebral palsy from quite complicated delivery at that time. So we felt she had a severe intellectual disability in that on conceptual domain, she couldn't really calculate, she couldn't really read any written language. On social domain, her communication was there. She could communicate in single words, but very with limited vocabulary. She could maintain some relationship with the close family, as in she could recognize families' faces, but still she needed fair bit of support on that. On practical domain, she needed some support for all self-care, such as showering and toileting. So based on those, we felt she was her severity is a severe intellectual disability. And intellectual disability, although people, it's such a heterogeneous group, so people can have varying level of capacity and function. But as a group, again, people have with intellectual disability have over a higher rate of comorbid illnesses. And we know that although people with intellectual disability have at least as much as frequent visit to GPs to the rest of the population, but we know that they have less access to preventative healthcare screening. So there was a qualitative study done on in Victorian GPs on this issues, and the barriers identified. The main issue was the communication. So communication with the patient, history taking, and thorough physical examination was quite difficult in many cases, and the communication with family and other healthcare professionals involved in care of people with intellectual disability was not easy either. And other barriers identified include a perceived lack of exposure and training in providing care for people with intellectual disability, and lack of awareness or on local services available for people with intellectual disabilities. And those are not easy barriers, but at least in part, our service exists to address those barriers. And we know that people with intellectual disability, especially people with severe and profound intellectual disability, they have reduced life expectancy. And more studies point out that it's not because of a genetic predisposition from the condition, but it's rather limited access to the mainstream health and unmet healthcare needs. So so this study is from Scotland. It's a population-wide study in Scotland, coding data from primary care. So they looked into standardized prevalence rate, and as a group, roughly 70% of people with ID had some comorbidities. And when they compared those to people without ID, mental health was more common, hearing loss was more common, and epilepsy was relatively common in people with intellectual disability, around 18%, which translate into roughly like 70 of odd ratio. And the constipation is more common as well, roughly 14%. And that was certainly case for patient KY. We did abdo X-ray and pelvic X-ray, initially looking for just location of IUD, which is put in many years ago, but we also found quite extensive fecal loading, and it can be quite difficult to track bowel habit in people with double incontinence, which was the case for KY, because even overflow incontinence could be falsely reassuring as a regular bowel motion. So utilize, regular bowel chart, ideally something with standardized, such as Bristol stool chart, would be quite helpful in managing constipation. And the dysphagia is quite common as well in people with intellectual disability, again with severe and a profound intellectual disability. And we were worried about patient KY because family noted that KY's drooling significantly increased last 3-4 months, and increased or new drooling can be sign of new dysphagia. Obviously, they cannot swallow their saliva as much as they could before. And the other symptoms of dysphagia, it's quite similar. It's something we all know, just coughing after swallowing, delayed initiation of the swallowing sequence, and but we also know that just a tearing or watering of eyes after swallowing can be sign of silent aspiration. So that's something we look for. And dyspepsia of all cause is more common in people with intellectual disability. So we actively look for reflux disease and proactively treat with PPI to see if it improve any discomfort or a behavior of concern, if there is any. And we know that as a group, people with intellectual disability have higher rate of potentially avoidable deaths. I believe it's roughly 5 times higher than general population, and I believe it's from the Ombudsman report a few years ago, done on people with intellectual disability in residential care. But we also know that average age of death is around 20 years less than general population, and apparently it also depends on the severity of the intellectual disability as well. And the leading causes of death, so for the respiratory disease is mostly aspiration pneumonia, and the regular speech pathology assessment is something underutilized, and aspiration pneumonia certainly is preventable, at least to some degree, if we provide appropriate consistency of the food and fluid, and other I think condition or cause of external death to mention is the choking, again, because we as a health system in general, probably we underdiagnose dysphagia, and so the choking is more common with people with severe intellectual disability. It can certainly happen in other conditions such as stroke and Parkinson's disease, but so choking does happen, which might be preventable. And when we say nervous system disease, it's mostly epilepsy as a leading cause of death, and the circulatory disease is ischemic heart disease, and neoplasm. It's quite similar to general population, so it's mostly colon cancer, breast cancer, and lung cancer. But we know that as a group, people with intellectual disability, they tend to get a delayed diagnosis of cancer, and the stages tend to be higher than general population as a group. And I might repeat myself for some topics, but you know, these are commonly missed health problems, and these are things we really look for during our clinic. I talked about constipation, and obstructive sleep apnea is something we look for as well. Although many may not be able to tolerate CPAP masks, still we can do something about their weight. So and the dental review can be quite challenging. It might be difficult to be tolerated. So some people with ID may need sedation for review and treatment. Reflux we really look for, as well as dysphagia. And nutrition is quite important, and it's relevant to patient KY as well, because despite regular oral supplement for some time, her weight remained 38 kilograms, so she was underweight, and hopefully the speech pathologist, a speech therapist input may help dysphagia and the nutrition state as well. And the medication adverse effects, so we try to rationalize medication and try to reduce psychotropic medication as much as we can, although sometimes people with ID may need psychotropic even without mental health diagnosis, but surely avoiding polypharmacy and minimizing psychotropic would improve on their frailty side of the thing. And we recommend, we look for and recommend regular hearing and vision check, and especially with functional decline or a behavior of concern worsening, we look for source of the pain, and we review mental health, and we are quite lucky to have psychiatrists specialized in intellectual disability in our team, so that's quite helpful. And in terms of the dementia screening, there is no specific diagnostic test for people with intellectual disability, but it's often heralded by functional decline, and the approach is quite similar. So we want to rule out any reversible causes by doing some brain imaging and some blood tests. And a 3D network from UNSW, they published guideline for dementia screening in primary care setting, which is quite helpful, and it's quite recent as well. One thing we different though is we look for dementia from younger age than general population. Sorry. So as we know in trisomy 21, because they have extra copy of amyloid precursor protein, so it can start as early as 30, and if people with Down syndrome are diagnosed with dementia, at least half of them, I think the age is around, a median age around early 50. But in other with ID from other causes or non-causes, we start to, in general, we look for dementia from age of 40. But I think what's most important information is, again, this collateral history of functional decline. There are a few screening tools we commonly use in our clinic. So adaptive behavior dementia questionnaire is quite helpful. So it can be one-off if we have reliable collateral history, and it has a cutoff on the score as well. So it's easy to interpret. But it's from UK, and sorry, I couldn't really find, and it's copyrighted, but I couldn't find the source or where we can actually buy. But the second one, DLD, or a dementia questionnaire for people with intellectual disability, it's another commonly used one, but this screening tool need a baseline prior to functional decline. So it would be ideal to get one done, maybe in their late 30 or early 40s, so that it can be compared in future. And both ABDQ and DLD rely on informants. So it could be family, it could be carer, but it's all, based on reported functional decline on various domain. In terms of the mental health screening, so we know that mental health conditions are underdiagnosed in people with intellectual disability, but I think we need to pay more attention if there is any new behavior or worsening of pre-existing behavior, because it cannot be solely from the causes, underlying causes of intellectual disability. Yes, some genetic syndrome may predispose people onto certain mental health condition, but not every condition do that. So observations are quite helpful and quite important. So the assessment of the mood, there are a few helpful screening tool. Actually, if you just Google this assessment of mood in people with an intellectual disability, it will lead to the 3DN document. It's a 2-page document, but it's quite helpful because it has a summary of different screening tools and the link to access particular items, and I found these two quite accessible and helpful and relevant to our practice. And the depression in adults with intellectual disability checklist is from Monash, I think. And it can be used across different severity from mild to severe. And the Kessler scale, it can be used, but it's a self-reported screening tool, like most of the mood screening tool we use in hospital or in primary care. But because of the language components, it can be only used in people with mild intellectual disability. And in terms of the general screening, it's the same. We just follow a national cancer screening. There might be some access issue, but the timing and the way it's screened, it's quite it's quite similar. In terms of screening in aging, in frailty, so I still do all the jerry bloods, depending on their age. And we look for osteoporosis from earlier age, from age of 50. We really look hard on those major risk factors, and if they are qualified, then we recommend or arrange DEXA scan so that we can treat. And osteoarthritis, again, and yes, for patient KY, we did recommend jerry bloods and recommend DEXA scan because we found some risk factors for osteoporosis. And the osteoarthritis, we look for osteoarthritis through X-ray as well, as just to rule out as a cause of frequent falls. And we also recommended vision and hearing screening. And because we know H. pylori is more common in people in any communal sort of residential care setting. Certainly it was case for patient KY who spent most of her life in residential care setting until recently reunited in family home around 5 years ago. So we arranged urea breast scan. But if someone cannot tolerate, and then we will we try H. pylori serology instead. And some of you may know very well CHEP, Comprehensive Health Assessment Program. It's developed by a GP from Queensland. It's quite helpful, quite informative, quite comprehensive. And then, as you know, we can use that health assessment Medicare item for CHEP as well. And it can be purchased. I think it's $11 per practitioner. So it's not that expensive, but it's really helpful tool. So that's it from me. I will pass on to Kelsey.
Thank you very much. I'm just going to get it going again. Sorry about that. Okay, so thanks, Yong. I'm just going to talk about the reasonable adjustments we can make at all different levels to manage health conditions for people with intellectual disability. But specifically tonight, just based on time, I'll talk about engagement and assessment. So I should say that the University of New South Wales, Sydney and the Ministry of Health have worked together to publish a practical toolkit for working with people with intellectual disability. So a lot of this information has come from here, and we have plenty of books. If anyone is interested, we can send around that go into detail about all of these sections. So looking at enhancing engagement, there's a few subtopics, I suppose, that we can do to support people with intellectual disability. I wanted to point out actually that in 2015, a study, 95% of health staff across the local health districts had no routine supports and adjustments available for people with intellectual disability, and 73% of staff had no training in intellectual disability. So I think it's important that we can make some adjustments, knowing that the life expectancy for people with intellectual disability is shorter. So these are some of the things we can do to support people with intellectual disability. So we can prepare before the appointment. So thinking about their strengths and support requirements, and also thinking about building rapport with the person. So we know this is important for the general population as well, but it's particularly important for people with intellectual disability. And we can do this just by starting conversations around something that might be a common interest. So thinking of hobbies and sports, or even just by looking at, for example, what they're wearing, and even asking about the colors that they like, or they might have a certain team logo that you can ask about, really to build their rapport with you and their confidence in communicating and getting the most out of the session. Also, capacity to consent. So we need to know what their level of comprehension and capacity to provide informed consent are. And with that, working with other decision makers. So do we need to have legal guardians on board and other decision makers, whether it's family, a part of those consultations? We need to confirm understanding, so using communication methods that are preferred by the person with intellectual disability. It helps to pre-prepare for this, so asking clients to bring their communication devices if they have something, or know a little bit about how they prefer to communicate, and also trying to do that yourself. So if it's that they prefer to write or draw to communicate, then even doing that yourself while you're providing information to them can create a communication environment that feels comfortable and safe. So engaging all parties, so the person with the intellectual disability is obviously the centre of the care, but who else needs to be involved? Is it family, support networks, and do we need to retrieve some information before the appointment? So for example, we know that in a supported accommodation, there might be staff that have worked with the person with ID for 20 years, and then there might be other staff with high turnover rates that might be on their third shift. And often it's the case that the person on their third shift is the one accompanying the person with ID to the appointment. So making sure, if possible, that we can have someone that knows the person really, really well, not only to feel comfortable, but also to enhance that the care planning and intervention based on the information that we gather. So providing accessible information is really important. Easy read, fact sheets, these are all over the web in different organisations. So I know there's diabetes or lots of different organisations that now have easy read fact sheets, and even in different formats that the individual might like as well. So that might be, I think I speak about a little bit later, but using real objects to describe something. So whether you need to do a blood pressure test, then holding it up while you're talking about it can really help their understanding about one, processing what's to come, and also understanding the information you're providing. Also seeking specialist assistance, which we'll talk about the services a little bit later, and a little bit more about the specialist intellectual disability health team. So some assessment considerations, and I know some of these things are easier said than done, but they're just considerations and things to think of. So familiar settings, if possible. If appointments and assessments can be done in home environments or school or day centre, then it can be really helpful to have that familiar environment. We are actually a telehealth service, so we promote assessments through telehealth as well. So if that is an option, then that's something to consider as well. We also need to consider reducing stimulation. So whether this is in the wait room or even in the appointment itself, it's thinking about what else can be done to reduce that stimulation. We know that auditory stimulation and visual stimulation can be sometimes triggers for people, and it might paint a different picture of their presentation just from that sitting in the wait room before. So could they sit in their car outside? I know this is something we're doing quite often now in the current environment, but maybe it's something we could consider more long-term as well. Avoid long waiting times, and I know this is a tricky one, but a strategy possibly to help with this could be having the client or the carers call ahead of time just to check in to find out how the time is going, whether they could come a little bit later if things were running behind, just to avoid those extra long waiting times. Sorry. Also, very important to greet the person with intellectual disability first and directly, and continue to do this throughout the appointment. So direct questions to the person with the intellectual disability, even if they are non-verbal and they haven't brought their communication device. It's really important to treat them as the sole person for the consultation. the last one that I've already spoken about a little bit is to get consent for third party to be present. I mean, at all ages, it's important, but I'm thinking more about sometimes people feel comfortable having someone, a family member or staff present for many of their medical conditions, but sometimes they might get embarrassed as well. So it's just checking in constantly to see whether it's okay to discuss this, that topic with a third party. So speaking now about communication and how we can support the understanding of health information for people with intellectual disability. There's approximately 60% of adults with intellectual disability who experience communication difficulties, and around half have actually reported having trouble communicating with health professionals specifically, which is a little bit sad. So there's some things that we can do to enhance our communication, and that is to increase communication opportunities. So I spoke about offering all questions and information to the person directly and letting them have their say. And something that might feel quite uncomfortable, but it's really important, is to give them that extra time to process the information and to process what they might like to say as well. So it's very tricky to wait 10, 20 seconds, but sometimes the information you will get out of waiting that extra bit of time for someone is invaluable, whether it's verbal communication that they come back with, or whether it's body language, or even just to paint a picture of whether they're understanding what you're saying or not. It's really important to give them, to offer them that time to communicate. We also have to consider the barriers, so the environment, noise. Is there some technology that's beeping constantly, or is the light flickering? These can be not only triggers, but also they can consume the person so that they won't be listening to anything you might be talking about as well. It's all they can think about and see. We also need to consider the communication needs of the person with intellectual disability. And you can see from the two diagrams here, I have unaided supports and aided supports. And it's important to note that we, at all times, have our unaided supports with us. So that is our body movements, our facial expression, our natural gestures. And I don't expect everyone to know sign language or keyword signing, but there's actually a lot of natural gestures we use in everyday conversations with our friends and our families to communicate. And it's the same with people with intellectual disability. And now, sorry, I've just realized my webcam's not on, but I'm just going to demonstrate a few of these for you. So if we're saying sit down, we can gesture that, or sit up, or even some things that you might do with family or friends. If it's quite noisy in an environment and they're far away, you might gesture for drink. So all of these are quite natural gestures that we use on the daily anyway, but just to keep in mind to use them in your practice as you're speaking to people with intellectual disability. It just provides a whole nother means of understanding. And something that I find quite interesting is the words that we speak only actually make up 7% of the understanding of what we're saying. So the rest of the information that we're taking in and processing is actually based on body language, our facial expression, our intonation, and how we say things. So that's really important to note as well, just to make sure you're using your body and your hands and your face to communicate with someone with intellectual disability. The other diagram is aided communication and aided devices. So that might look like iPads or something that needs to be predetermined and brought with people to the appointment, but it also can be some things that we can make as well. Can we have some visuals there? I know there's some great pain charts for people with intellectual disability or cognitive impairment, so they might be a great resource to have just on hand as well. We can also use, as I mentioned, the real object. So if you're talking about asking someone whether they can read or write, it helps to go, can you read and write? And they might get a lot of information just from having that real object. And you can gesture towards things here as well. So can you please hop up onto the bed rather than just speaking it with our verbal, with our speech. So I've just popped here some communication tips. So this is an example of Easy Read, which I mentioned before. I've covered some of these tips already, but I thought it might be a good opportunity to see what Easy Read looks like. So it's having some simple language with a picture. So I've spoken about body language and environment, building that rapport, and also allowing additional time if possible. I know that's a tricky one, but if there is time to give, then that's a good strategy as well. One topic at a time. It's important just to stick with one topic or one health condition at a time, even, just so it helps with the processing time and the processing speed for the understanding. And also regularly check in. And I've got a diagram on the next few slides as to how we can do that. Repeat and explain information. Really take notice of body language here as well. You can pick up a lot on whether someone's engaged with what you're saying, whether they're understanding, whether they're looking to their support person, maybe to explain it in a different way or to simplify it for them. So I've covered those ones here. So Easy Read as shown. Also, just ask communication preferences. It can be a little bit funny sometimes to feel like you should ask, but you definitely should. People with intellectual disability actually really like that opportunity to be able to say how they communicate, and they will often show you. So the Teachback method, I'm sure you're probably all aware of, but it is a really, really important one specifically for people with intellectual disability. So we need to use simple terms, check understanding, keep clarifying, rechecking if we need to, present it in a different way to really ensure that that understanding is there. So now just wanting to talk about services. So where do people with intellectual disability go to receive health services? Well, I'm sure you're not surprised, but there's only a small percentage of people with intellectual disability who receive specialist services, and the rest of the population, they go to general GP practices and New South Wales Health hospital systems. So there's five tiers, which is the current model, and you can see there I've highlighted our specialist service there as well. We know that not all services have the same amount of time and specialised skills for people with intellectual disability. But as Yong said before, there's some allowances there. I mean, GPs can access Medicare rebates for tools like the CHAP that can provide that little bit extra time to spend with someone with an intellectual disability. As Yong also mentioned, on average, people with intellectual disability have 5 times more medical conditions, and studies show that despite having access to primary health care, 42% of people have conditions that generally have been undetected. So of these conditions that are diagnosed, only half are managed adequately as well. So we do understand there's time factors and skill levels, and we're also aware that that sometimes not even the client themselves are able to express that, and sometimes staff and carers and family aren't actually aware as well. Now, to speak a little bit about the Specialist Intellectual Disability Health Team, we are a relatively new service establishing towards the end of last year, start of this year. We, as you would know, cover Western New South Wales, but we also provide services to Far West and Murrumbidgee local health districts. And with that, we have intellectual disability clinicians on the ground in those regions that can support from their end as well. We are a virtual, we have a virtual healthcare model, and with that we have a multidisciplinary team. So we have our few doctors, which are our psychiatrist, our rehab physician, and our paediatrician, along with our CNC and also our allied health, which is the social worker, and myself, the speech pathologist. And together we provide a very thorough assessment for people with intellectual disability who have unmet health needs. And we also, another component of what we do is providing capacity building to health staff in how to assess and provide intervention for people with intellectual disability. So just talking about the criteria, so I have mentioned to have a referral into our service, the client will need to have an intellectual disability. And yeah, Yong has gone into a little bit about what that looks like. And they also need to have unresolved health problems and unmanaged chronic and complex health issues. I'm going to talk a little bit about some common referrals that we will receive that might help to show what this looks like as well. Just before I do though, we can be referred to via email, or even just a phone call is a good way just to touch base and see whether it's worth a referral, whether they meet our criteria, and then we can send through some information as well. So a few referral examples. So new behaviours of concern and wanting assistance with establishing if there's any underlying cause. So this is a very, very common referral that we receive, and it can be a referral of that alone. So new behaviours of concern, or it can be accompanying with some other unmet health needs as well. So some of the common ones we see might be an increase in aggression or obsessive traits even, and we can do a very thorough assessment to find out if there's anything underlying this. The second is barriers to accessing timely health services. So this is also quite frequent of a referral that we will receive. And it might look like the client needing to have some medical imaging done under sedation, or it could actually be that they need quite a few services and trying to organise that in a timely manner under one admission. And it's quite difficult to do that, and we realise that that sometimes that time factor in organising that can lead to some serious health outcomes as well, unfortunately. It's worth noting though that our team are looking into and developing referral pathways so that this can become something that's quite easy to do, and there's some pathways in place. But of course, if there's anything in the meantime, or anything quite urgent, for example, a patient with cancer, it is definitely worth giving us a call, and we can help with that process too. The third is differentiating between intellectual disability or major mental health conditions causing behaviours of concern, which we have recently seen in a paediatric patient. So there was quite a lot of capacity building in this referral. Something that is probably quite common for GPs, I would imagine, is NGOs coming with the patient and saying that they need referrals to X, Y, and Z. But sometimes it's about providing that assessment and realising that it might actually be some education and capacity building for the NGO themselves in what the diagnosis actually looks like for that person with intellectual disability. Saying this, I will just mention, so we do provide capacity building to health staff about general topics relating to intellectual disability. And for NGOs, we're not set to provide generalist support, but we can absolutely do that if it's related to a specific client. So in summary, we do provide a very comprehensive assessment, and sometimes we will receive a referral for one thing, but due to the nature of our assessments, we really look into all the different areas. An example would be of a client that was referred for a different health issue, but during our assessments and investigations, it was noted that she had an intrauterine device, which Yong was mentioning before, put in place over 10 years ago, and there was no notes about saying whether it was taken out or what was happening there. So we thought it would be a good idea to do some scans, and it was in fact still in there but dislodged slightly and in the wrong place. So this could have been causing the patient some pain or discomfort or change in behaviours for up to 10 years possibly. So with that, we'd like to open it up now for any questions for myself, Yong, or the team.
Thanks, Kelsey. There are a few questions that have come through. Please, if anyone has questions they want to add, just use the questions box down the bottom of your control panel there. To start, we've got a question from Jane, who's a GP. Just in terms of making a referral, who do referral letters get addressed to? Is there a referral form or can they be faxed?
We do have a referral form that we are happy to share and send out, and referrals do need to be addressed to our doctor. So we have, as I mentioned, 3 doctors. So even if they're addressed to all 3 of them, that's okay, but they do have to be addressed specifically to our doctors for our billing purposes.
Question from Martin, who's a GP also. Where do you operate from?
So we are a virtual health service. We'll use the virtual model. So we actually operate from not just all over the state, but Yong is actually based in South Australia. So we have a very varied team and we're spread far and wide, but we do connect morning and afternoon so that we are all on the same page and constantly updating each other with clients. So yeah, but there's quite a few of us based in Orange, but like I said, it doesn't really make too much of a difference. We can see people in Murrumbidgee, in Far West and in Western.
Another question from Jane, just wanting to know who the doctors are on your team.
Yong, do you want to answer that one?
Sorry, yeah, I was muted. Sorry. Yeah. So adult medical doctor will be me, Dr. Yong Kim, and we have a psychiatrist specialized in ID. Her name is Dr. Ria Leonard, and we have pediatrician again specialized in ID. Her first name is Julia. I cannot really pronounce her last name. If either Kelsey or Mary can.
Julia Scalata, and yeah, and if you do contact our team and ask for a copy of our referral form has the 3 doctors listed at the top as well. Sorry, my name's Maren. I'm the manager of the team.
Thanks, Maren. Another question from Alice. She's interested in the percentage of mental health disorders as a comorbidity with intellectual disability.
That's something it'll be, I think one thing I know is that as a group, I think the odds ratio or relative risk is one point something as a group, but it's a varied as well, and it's hard to answer because as a group you can say that yes, any psychotic disorder or schizophrenia, maybe relative risk is 6 or 7 times, but I think it really depends on the severity as well, like many other issues. I think so it's a bit tricky. I think we sort of we assume that people with more severe disease maybe have more mental health issues, but it will be obviously undiagnosed because the whole construct is mostly language based, but still we can sort of infer, or we can make some clinical judgment based on irritability, change in aggression, and so forth. So I guess the number, there will be different numbers, but it will be really depending on what investigators look into. But as a rule of thumb, as a group, I think psychotic is 6 to 7 times than general population. Mental health as a group may be a bit more than general population. I think that's as far as I know.
Alice just wondered also your comorbidity of autism.
Oh yes, that's quite common. Sorry, I cannot remember the number, but it's quite common. Comorbidities. Yep.
I'm just going to put the email for referral into the chat box for everyone. We do have another question from Dr. Lawrence. She's referred a lot to Dr. Madeline Dills at Bloomfield, but your psychiatry service is separate to her service. Jane wants to know.
Yeah, that's right. We work very closely with Madeline Delves. We're a separate service. We're one of 6 teams across the state that provide this short-term intervention, whereas Madeline's clinic is able to provide more of an ongoing care environment. But we do speak on a weekly basis with Madeline and her team just to confirm that that there is no wrong door, essentially.
Great. Just another request, if people attending tonight might be able to be sent the doctor's names via email, or perhaps the referral form.
Yeah, absolutely. Happy to send the referral form around, which has the doctor's names on it. We can also send some fact sheets which have all of our contact details on it as well.
Great. Does anyone else have any other questions that they wanted to add? Got a thank you from Jane for covering this very important area. Any other questions? Is there anything else that you guys on the panel wanted to add before we finish up tonight?
No, nothing particular to add from my end. We're very keen to receive referrals, and if you've got anyone with an intellectual disability that you'd like to just even discuss and consider whether they might be an appropriate referral, even if you think they do sit outside of our criteria, feel free to give us a call. And as I said, we work closely with any services that do see people with intellectual disability for specialty care across our region. So we'll make sure that your client's seen by the right service.
That's great, thank you, Marion. There is an evaluation QR code up on your screen now. If you could please give us your feedback, we'd really appreciate it. I'll speak to you, Marion, about sending some resources out to everyone who's attended tonight. And thank you so much to everyone on the panel for presenting for us tonight. And thank you everyone for coming tonight to listen to them talk. Have a good night, everyone, and thanks so much.
Thank you.
Thank you.